My first slide is actually where I'm coming from. It's for more than 20 years, I used to present myself as being the most northerly working periodontist in the world. Coming from a small city up here in the northern part of Sweden, Sweden is there, and you see it's very close to the Arctic Circle. We're actually talking about the upper part of Alaska. This time of the year, 24-hour sunshine. And yeah, most of them are winter pictures. Here's a summer picture. And we are very famous because we have an ice hotel, 1 out of 2 in the world, where everything is in ice. You can check into a room. This one is more in Egyptian style. And this guy, I think, had been hanging out in the bar a little bit too long. But the glass are in ice, and you don't need any ice cubes. So after 7 years in Los Angeles and even a short visit up in San Francisco, I ended up here in the Gator Nations. And they are as crazy as Scandinavians. But there is not ice hockey. Now it's college football. I'm showing this a little bit because I was lucky. I was one of the first periodontists in the Scandinavian countries who came into implant treatment. Professor Bronmark was very specific to start with a lot of guidelines. For example, we should not have pink porcelain. We should have acrylics on it, transparent acrylics. And of course, 27 years later, it's a little bit discolored. The other pictures here are probably 15, 20 years between that span. I put them there because sitting in the back there and see all these marvelous, marvelous aesthetics we are talking about, this was what the crazy Swedes came over with early 80s. And were so proud of and said, this is what we have, oil platforms. Anyhow, I gain a lot of time here because other speakers have been into this topic, talking about bone loss, 1 thread, 2 threads, and 3 threads sometimes. We have a case here after 1 year, and we see 16 years later that we really see a continuous breakdown here. And we had to start with, when I came into implants, all the articles were about implant survival, implant survival. So during the 80s, it turned over to talk about implant success. And of course, marginal peri-implant bone loss was a very important issue when it comes to this. So what kind of criteria? We already been in and talking to it. Thomas Albrektsson and co-workers, 1986, 1 millimeter the first year, and 0.2. We already seen that. It got even worse. During 1993, the first perio meeting, Euro perio meeting, these are the consensus from that. 1.5 millimeters and 0.2 millimeters annually. We also been in talking about what is it? It's bacterial colonization, it's design of the implant and so on, and you have some references there at the same time. So it wasn't until we start to see those showing up. Until we start to see other clinical, other aesthetic implants. And today we are selling it with the aesthetics first. And many times I'm a little bit questioning this. I mean, is that really where we want to go with all these implant treatment? I felt like the patients were as happy 1970s, 80s as they are today. So I'm not really sure if this is the absolutely best way of doing it. So anyhow, let's see now how good Alan is when he's doing his implant treatment. So in one of the projects, this is one of my residents, and we were going through as Alan said, we were going through the first 50 patients. We are going continuous checking up here, but I'm going to discuss to you the first 50 patients here, continuous patients, 36 women, 54, and as other speakers had talked about, there is no maybe need for wider implants. So of the 69 implants, 64 were 3.5 millimeters. We didn't manage to measure 7 out of the 138. So did he manage to place them where he said? Did he manage to place them subcrestal? Yes, he did. He wanted to place them 1 to 2 millimeters grafting. Actually, this is interesting because I think it's one of the few articles that few situations where you graft it directly in the subcrestal position. That's why we singled out these first 50 cases out of it. But we actually used, or he actually used PepG P15 to fill up that space there. One stage, as I said, antibiotics, and follow up for 14 months. We used an ImageJ system, which is available free from NIH. If you want to do measurements, you can just go in on their website. And a magnification of 7 times. We measured from the platform, and we measured the crestal height from a line aligning the implant like that. Most of the cases, as you saw in his presentation, were upper incisors, but there were a few other teeth too. So the results. Did he place them subcrestally? Yes, 1.3 millimeters. And here comes a number that I want you to remember. Loss of crestal bone. I mean, whatever we do perio surgery, we do implant surgery, we always get loss, some call it loss of bone tissue around it. In this situation, 0.6 millimeter. Is that good or bad? Is it normal? How does it compare to other results? The other part of it is how much bone loss do we get from the reference point, from where the platform ends. Forget the yellow, the blue, or the green, and so on. It's only telling you that there is no statistical significance between mandible, maxilla, female, male, and distal and mesial, and so on. Concentrate on the white instead. When we take all surfaces, 131, we get a loss of 0.1. And I mean, as a clinician, me being a clinician all my life, I mean, that you can't measure down to that. You have to really do magnifications to see these kind of things. And what's more interesting, 69% of them are actually showing bone on the platform. Or maybe I should say, because we graft, maybe I should say mineralized hard tissue on the platform. 69%. If we look at the cumulative frequency or percent of it, you see that almost all sites are out here. No bone loss, no bone loss, no bone loss, no bone loss. And it's only 10 surfaces who have more than 0.5 millimeter. One of the loser is here. And you see even the loser, I think this is even the worst loser. I think even the loser look fairly normal if we compare to many other implant systems. So how does it hold up with other systems? One of the other speakers were in talking about this study by Herman and so on. Once more, we can concentrate on the photos. You place an implant in different positions. This one is 1 millimeter subcrestal, this one is 1.5 in a 2-component system. And I think this picture tells it all. This is a dog study, as you see, the dog mandible, and you see that we lose 1 millimeter and a little more, and we lose at least 1.5 millimeter and a little more. So I give you the numbers. 0.2 down here from on the rough surface, and 0.4 down on the rough surface with a 2-component system. So add that together, 1.2 or 1.7, and you add the numbers that Alan has, is 0.7 approximately, like that. So it's holding up really, really well. This is another study then, when the new, I think this is the new Straman bone level implant. And the same, they were placing it 1 millimeter supracrestal, 1 millimeter subcrestal, and crestal. They had a follow-up of 6 months, and they didn't report any bone on the platform. And I think speakers has been into this before. What is it? Is it micro movement? Is it that it's maybe the Morse taper is a little bit too short? Or what is it? Anyhow, picture taken directly from the article. is showing that you lose 1.4 millimeters. In that one was 1 millimeter subcrestal and 0.47 millimeter in the other scenario. Which means, if you compare it to our numbers again, 0.4 millimeter, 1 millimeter, and in that situation, approximately 0.5. And Alan's numbers, as you remember now, 0.1 millimeter plus 0.6 millimeter. So 2 dog studies, it's really holding up well. There are not many clinical studies, direct clinical studies, who compare who is placing implants subcrestally with follow-up time. I took these ones, Christoph Heavily and the group around that one. And you see 1 millimeter subcrestal with a polished surface and the rough surface, and the test implant lost 2.26 millimeter and control implants 1.02 millimeters. So quite a lot of difference. I also heard speakers this morning talking about the smell when we take a crown off, when we take the abutment off under the picture, between the abutment and the fixture. And there is a smell. There's definitely a smell. We've heard this morning that we saw a leakage of liquid. The question is there microorganism in that too? And I mean, we know, we are used to see these situations where we have plaque and we maybe have pus sometimes and even bone breakdown. So for me, at least, a few years ago, when I got handouts from Dentsply regarding ankylose, I was reading this bacteria-proof connection. Is that really true? What kind of proof do they really have for that when they are saying it? And I couldn't really find it as saying. So I said, oh, this would be a really nice Master of Science project. So comparing these Morse taper, but what do we want to compare it to? Because we want to really do some research here, we need a control group. We cannot just go out and say this is okay. And the control group is fine. I think it's to choose one of the market leaders plus a system who has the indexing system on the top and who is a cylinder. It's not the Morse taper. And I found that was really an interesting control group to have. So we had to put it together with some creative thinking or stinking outside the socks. In another little study, bacterial colonization of the dental implant fixture abutment interface. So what did we do? Very simple. First of all, we needed 2 microorganisms to have here. What can we choose? Yeah, we knew that bacterial plaque around teeth, bacterial colonization around teeth, and around implant is fairly similar. Actually, it takes maybe 30 minutes before we start to see microorganisms around an implant. You have some references here. Or, yeah, so we chose 2, I think you recognized all of you. As periodontists, we call them AA and PG. And so we took these 2 microorganisms in a solution and put the implants in it for 5 days. Like this. Give 5 days for it. Disconnected them. Took a sample from the threaded part. Put it on plates in an anaerobic chamber. And we needed groups, as I said. We had the regular Morse taper group. But we also wanted another control group. We said that if we try to manipulate this system a little bit, we took the same system as before, but instead we made a little groove in it. To really be sure, now we must have leakage down there. It must leak down there with this solution. And as I said, we took the Noble Biocare system and had that as a control system. And once more, I think the pictures are talking for themselves. The test is here, 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 and a little blip there. I think it's contamination. We had a little bit of that. And you see the other groups here with the groove and with the replace select system. So the pictures and the numbers. If I take the mean numbers or I take the median numbers, I don't think it matters so much because they are fairly similar. And you see the groove colony forming units approximately 79, and here's 61, replace 34, 16, and as you see in the regular ankylose, it's fitting well with what we have seen this morning. It's not only about the leakage here, it's also about ingrowth of microorganisms. So, to look in the crystal ball, I think what we see here is absolutely right. And I think if we really want to say that it's going to be changes in the future, I think we are going to see more and more implant companies showing an interest just in this area of fixture abutment interface. And also implant conferences that is going to put more strict criteria. Not 1 millimeter first year and 0.2, coming down to more realistic values for the implant companies really to compete. And we have seen pictures like this too. How many different kind of implants are there in the world today? How many? There's a lot. Esbjörn Jogstad is the one in the world that I think has best control over this. And it's a couple of publications. It's 535 different kind of implants on the market today. 147 manufacturers. And more scary, it has doubled in 5 years. So where are we in 5 years? So my conclusion is very simple. The small project we have had, the time we've been working with ankylose, I think that Dentsply can be very proud of it. It's very easy to summarize it. It seems to be a very good implant system. Thank you for my part.